Next, it's my pleasure to introduce Dr. Kevin Ghassemi, who is our Associate Director of Clinical Programs at the UCLA Center for Esophageal Disorders. And what you may not know is that not only is he a UCLA alum, he did his residency and fellowship here, so you look at triple threat here. All right. Kevin is going to talk about eosinophilic esophagitis and what is new in the disease spectrum.
All right. Thank you, Rima, and thank you to everyone for coming and for the invitation to speak here. So the agenda for today, or at least for my talk, is to talk about some updates in terms of what's new, the diagnosis, the management, and managing complications, and then also to make the case for and against the different types of treatments for eosinophilic esophagitis, so the what's right part. So just a few fun facts or some statistics. The prevalence is about 57 per 100,000 people. That includes both adults and children. About 150,000 cases in the USA itself. The peak prevalence is in men that are at the age 35 to 39 range, where the prevalence is 115 per 100,000. This is a clinical and pathologic diagnosis. So the guidelines recommend taking biopsies from both the mid and the distal esophagus. You need to have at least 15 eosinophils per high-powered field in order to make this diagnosis. Keep in mind there are other causes of esophageal eosinophilia, so just the presence of the eosinophils alone does not cinch the diagnosis. And in terms of sensitivity, it's important to take at least 5 biopsies overall. The studies have shown that there's 100% sensitivity when you take at least that many biopsies. Now, just to point out, I'm not going to be talking about the concept of PPI responsive esophageal eosinophilia, which some consider its own diagnosis as opposed to, say, an offshoot of EOE. So the guidelines recommend that you do an 8-week trial of high-dose PPI twice a day to determine whether they have this condition or not. Okay, so first I'm going to get into some diagnostic updates. There were a couple of studies that came out of North Carolina looking at different ways to test for eosinophils with the goal to either be non-invasive or just to reduce the number of biopsies that you need to take. So the aim of this first study that I'd like to review was trying to determine if there were serum biomarkers that could be used to make the diagnosis of EOE or for monitoring. And so in this study, they looked at 2 groups, those who had EOE and those who had either reflux or some other etiology for their dysphagia, but not meeting EOE criteria. And so they checked a panel of inflammatory markers, which included a number of interleukins, TNF-alpha and beta, and several eotaxin variants. And what they found was that there basically was no difference between EOE patients and those who did not have EOE in terms of these levels of the various inflammatory markers. And then there was no difference when looking at EOE patients pre- and post-treatment as a way of determining whether there was a response to therapy non-invasively. So conclusion from this study was you need to still take biopsies to assess, to make the diagnosis and also to assess for response. So the next study that came from this North Carolina group was to look to see if maybe you don't actually need to biopsy. And so in this study, they looked at a variety of clinical and endoscopic features to predict who had EOE without obtaining biopsies. Again, they looked at the same 2 populations, those who had EOE and those who didn't. And they found that patients who had the clinical factors of young age, male gender, complained of dysphagia, and had some history of a food allergy, and also had endoscopic factors including rings, furrows, plaques, and the absence of a hiatal hernia, was highly accurate for diagnosing eosinophilic esophagitis, 92%, with an area under the curve of 0.944. So some limitations of this study that, despite looking over this study multiple times, it's unclear if all factors had to be present. I would assume that that would be the case, but what happens to the sensitivity or the accuracy if you have 7 of these 8 factors? It's unclear. And then they also did not delineate whether you had to be on a PPI at the time of the endoscopy to make this kind of diagnosis. So for the time being, you still need to take biopsies to confirm EOE. how about if you're going to take biopsies, is there a way to actually improve the diagnostic yield? And so in this study, what they looked at was whether the specific endoscopic appearances could predict the degree of eosinophilia. So they actually took a lot more biopsies than what's normally required for purposes of proving their concept. And in this study, they took up to 32 biopsies at various sites along the esophagus, and they described the mucosal appearance at each biopsy site. So taking a break from the study just to show the different types of endoscopic appearances. In part A, you see the linear furrows that go down the esophagus. On slide B, you see the exudates, these little white spots here. Then you have the lines on the left and the much more obvious rings on the right. The way I would distinguish between lines and rings, because the consensus statements don't really distinguish between these two, is that lines look like more subtle and probably more incomplete than actual rings. So in their study, they found that where there were furrows and exudates, there were higher eosinophil counts. The lines and normal mucosa never really reached that 15 eos per high-powered field threshold, and then the rings alone were not necessarily associated with increased eosinophils, and they were seen in both patients who hadn't been treated and had been treated. So what they concluded was that you might not need to take quite as many biopsies if you have the furrows and the white patches or the white exudates, because that's a sign of active inflammation, whereas if you don't find those types of endoscopic features, you're probably going to need to take more biopsies to improve your yield. Moving on to therapeutic updates. So really the focus over the last couple of years has been with regard to elimination diets. One of the treatment options, at least dietary-wise, is a 6-food elimination diet. And it's been effective, the 6-food has been effective to the order of about 75%, but it can be quite restrictive. And just to review, the 6 foods are wheat, dairy, soy, nuts, eggs, and seafood. And there are some other variations. The Spanish group also might restrict corn, legumes, or even rice, depending on the study. So what about a 4-food elimination diet? I keep getting mixed up with the first F. I sometimes think of this as force-fed because it is a tough diet to really swallow. But with this study, they did 6 weeks of the 4-food elimination diet, and they defined a response as both clinical, so symptom improvement, as well as histologic response, basically no eosinophils. Those people who responded then underwent a reintroduction phase over about 6 weeks, and then it was followed by a repeat endoscopy and biopsy, where the non-responders were then offered the 6-food elimination diet. So how did this fare? About half of patients had a response with the 4-food elimination diet. 31% of the non-responders, when they were offered the 6-food elimination diet, responded. And actually, I think I forgot to mention, but the 4-food elimination diet consists of avoiding milk, wheat, eggs, and then soy. Now, in these 4-food elimination responders, the trigger was most often milk. But as you can see, 27% was the sole trigger, so most people actually had multiple food allergies. Eggs, 36%, which is actually much higher frequency than the literature states, whereas closer to 5 to 10%. Wheat and legumes, you can see a little bit lower. So the bottom line here is that the 4-food food restriction diets can be potentially helpful and maybe less restrictive than initially thought with this 4-food elimination diet. Well, how about if we try to predict the food by IgE-targeted elimination diet? So here, the background is that most allergy testing has been with skin prick testing, and when looking at how predictive it is, it's actually pretty poor. Most literature suggests it's about 10 to 20% effective in predicting the causative factors. So in adults, though, food-specific serum IgE has actually not been well studied. So in this study, what they did was they compared a 6-food elimination diet to specific IgE-guided therapy, elimination diet. So people who were found to be sensitive by IgE serum to various foods underwent elimination of those foods, and then there was another group that had the 6-food elimination diet. And that was the people who did not have specific sensitization with IgE. They defined response as less than 15 eosinophils per high-powered field, and then those people who responded underwent food reintroduction to confirm whether that was actually the case. And then the non-responders in the specific IgE elimination diet, they underwent the 6-food elimination diet. So, as expected, the people who had specific IgE elevations ended up restricting fewer foods, on average about 3 to 4 foods versus the 6-food elimination diet. In most patients, wheat was withdrawn, but nuts and milk were actually not that far behind in terms of withdrawal. And they found that the histologic response was actually better in the specific IgE elimination diet, although the p-value was not significant, probably because the numbers were low. And in this study, they found that the causative food was actually most often milk, much less often the foods you can see there, like wheat, egg, and legumes. And when they looked at correlation, really the only predictive IgE that was highly correlative was milk. So what can we take from this? It looks like the specific IgE elimination diet might be as effective as 6-food elimination diet and potentially much less restrictive. So this could, if it pans out with future studies, could actually change the paradigm for how we do food elimination diet, because it can be a lot less restrictive and actually bring allergy testing back into the mix to help determine what to do. And then just a little bit on managing complications. Of course, the most feared complication when dealing with EOE, at least when treating, is perforation. So the risk of perforation in EOE, based on the literature, is actually less than 0.1%. The main mechanisms that are thought to contribute to this are prolonged food impaction, leading to localized inflammation from the pressure, as well as related to dilation or biopsies. And you can see an example of a tiny little hole right here in the center of that ulcer. This is actually after a dilation was performed. The the current standard for management really ends up being conservative in most cases. A lot of patients who have a perforation, it's more of a microperforation, evidenced by pneumomediastinum on a chest X-ray or CT, but actually no contrast extravasation. And so these patients are managed conservatively, kept NPO, given antibiotics, usually do better within a couple of days and can resume a normal diet. In some cases, though, the perforation is more significant and esophagectomy has been performed. About 2 years ago, when I gave this talk, there was actually nothing that I could find in the literature on the use of stenting. The thought was, don't do it because it can cause severe pain due to the underlying full-thickness inflammation that goes along with eosinophilic esophagitis. Although the biopsies are from the mucosa, the problem actually extends through the muscularis. And there's risk of further trauma in the setting of patients who have untreated or undertreated inflammation. But there have been a couple of case reports that came out. One actually had 2 cases, and that's the first one here, where they used partially covered self-expanding metal stents and to treat a complication, which was the perforation. And in both of these cases, there was tissue ingrowth, which required a stent and stent technique that Dr. Sederat talked about in order to retrieve the initial stent once the perforation had healed up. There was another case report using a fully covered metal stent in which everything went very smoothly. And in neither case was there a complication such as stent migration or fistula, for instance. So this may be something that is an option. I don't think that it should be used willy-nilly, but at least something to consider and not necessarily having to go to esophagectomy. So overall, there haven't been any major changes or updates in terms of what's going on with eosinophilic esophagitis. But I think this being more of a case-based forum, we should talk about how do we approach these patients. And I'd like to just illustrate a few quick cases here in terms of what might be the right way to proceed with these patients. So this isn't going to be an audience response thing, but just think about each of these cases that I'll go through briefly. You have a 28-year-old woman who has once-a-week solid food dysphagia. Endoscopy here shows the classic features of EOE, the rings and the linear furrows. There is no stricture present. Of note, she already has a documented anaphylactic reaction to dairy. So this is someone who probably, on one hand, you could think maybe she's willing to do more food elimination diet because she's used to it, but on the other hand, she already feels quite restricted in terms of what she has to eat. So think about what options you would want or to consider for her. For case 2, you have a 17-year-old girl. Twice a month she has solid food dysphagia. Her endoscopy shows a pretty similar appearance to the previous patient. No stricture, you can see the rings there. She comes with her mother, who is very anxious about her possibly having to take medications for the rest of her life. So what options might you consider for her? And then finally, you have a 39-year-old man who had a recent food impaction. They didn't make a diagnosis at that time, and he comes for follow-up endoscopy. And trust me, this is not the trachea. This is the esophagus. You got major ring-like formation, and you can see the saliva that's retained there, which suggests that there is some outflow obstruction. And then here at the esophagogastric junction, there's a marked narrowing, and you can see the pulsion diverticula that have formed from the long-standing obstruction. So he gets dilated from 8 to 10 millimeters. You tell him to follow up to discuss the long-term treatment, and like most EOE patients, you don't see him again until there's another problem when his dysphagia returns. So how are you going to treat this guy? All right, so just a brief overview of the treatment options, and the asterisk there is to just note that we have excluded PPI, responsive esophageal eosinophilia. So they've undergone an 8-week course of PPI, and they have not improved. So steroids, two main ways of delivery are either with using an inhaler that's swallowed topically. The literature looks at swallowed fluticasone, and the treatment dose is 880 micrograms or two puffs of the 440 twice a day. There's oral viscous budesonide, so taking the budesonide respules and mixing them. The literature talks about Splenda, although I don't know that that's an absolute necessity for the medium, 1 milligram twice a day. And then elimination diets, we've kind of talked about the 6-food and the 4-food elimination diet, and there's possibly a role for specific IgE targeted or allergy-targeted therapy. And then dilation, and the two main ways of dilating are the wire-guided bougie and the through-the-scope balloons. So why should we do steroids? Well, they've been shown to work. There are numerous studies that have shown that there's symptom response, there's histologic and endoscopic response. As mentioned, they lead to symptom improvement, and there was one study that suggested there might be some improvement in the lamina propria fibrosis. They're also safe. There's no serious adverse events reported, and there's minimal systemic absorption generally, just like using an inhaler for the lungs in asthma. And in milder cases, they can be used intermittently. The 2007 consensus statement and supported with the 2011 statement was that you could use for 2 to 3 months and then stop and then resume when symptoms recur. And there's no evidence that that has any long-term detrimental effect. But why shouldn't we use steroids? Well, the symptom response is unpredictable. Just like I told you that there are numerous studies saying that they work, there's a lot of studies that saying that they don't work, either from a symptom or from a histologic standpoint. Reasons for that are not necessarily clear. Esophageal candidiasis is the main adverse event, but this is most often found incidentally on follow-up endoscopy, and patients usually don't complain of dysphagia as a result of this. And relapse is common. By 9 months, 90+% of patients will have relapse of their symptoms. Moving on to the food elimination, we should do this in patients because EOE is really considered a disorder of the young, so why not institute a lifestyle change that they can continue for the rest of their life rather than possibly having to take medications for the rest of their life? It also can be considered as another option for people who don't respond to steroids, although in the guidelines from the ACG, it's considered one of the first-line treatment options. But it does have its downsides. First of all, if you resume the eliminated food or foods, the disorder is likely to recur. It can be difficult, particularly with milk avoidance. It's not the lactose, but it's the milk proteins, which can be found stealthily in a number of foods that we would not expect to have milk. It can be difficult to predict the causative food in general, and sometimes it's multiple foods. If the symptoms are infrequent, the standard 6-food elimination diet of 6 weeks may not be long enough to determine if there really is a response. Someone who has symptoms once a month, maybe it was a fluke that they didn't have it that month. And then similarly, if you find that they get better, it may take a longer period to reintroduce the foods because, again, it may not have occurred that quickly. This certainly can impact the quality of life. If you're avoiding so many foods to not have the dysphagia symptoms, you sacrifice your quality of life from a culinary standpoint and eating out with friends and so forth. And it can be unrealistic for some people who have to eliminate more than one food because it can be very restrictive. So what about dilation? Well, Dilation works to provide immediate symptom improvement. Just like the third case that I mentioned, he was fine. When he finally came back to see me a year or so later, he said that he was actually getting dehydrated because now all he was eating was burgers. He wasn't drinking liquid like he used to. It really works well on that fibrostenotic component, and it's generally well tolerated with a relatively low risk of complications. It also can be quite effective. The mean duration of response can be over a year. So this can work for quite a while when patients are dilated to an adequate level. Recommendations vary because normally we think of trying to get people above a threshold of 12 millimeters in order to avoid significant dysphagia and food impactions, but a lot of patients won't feel a lot better until they're closer to 17 millimeters. So you may need to get them up to that higher level in order for them to have this kind of durable response. But why shouldn't we dilate? Well, number one, it doesn't treat the underlying problem, so all we're doing is treating a symptom, so to speak. People who have multiple strictures, which we see a lot, particularly at UCLA, you have to vary your approach because using a bougie may not necessarily work for all levels of stricture, and so you might have to treat based on the smallest diameter and stop there and then come back again and work your way up. With the balloons, you can alter how far or how much you dilate each site, but it's something that you have to be careful of when you're trying to pass a scope down. You might have some limitations there if you have a very tight stricture. And then, of course, complications, chest pain being the most common, and perforation, serious but fortunately rare complication. This is just an example of someone who had a proximal stricture that was 10 millimeters. It was dilated to 12 with this quite large tear right here, and she was basically calling for the next 5 nights with severe throat pain. Went to the ER. Fortunately, everything was fine, but it's a lot of sleepless nights for both the patient and the endoscopist sometimes. So with all of this, what's right? Well, as you expect, treatment needs to be individualized. For a younger patient who's committed to lifestyle change, the elimination diet might seem like the way to go. I recommend a dietitian consultation because as I mentioned, there are a number of hidden sources of various types of the food that you might want to eliminate in the patient. Patients who have frequent relapses might need to be on maintenance topical steroids. Typically what I'll do after 3 months of twice a day fluticasone or oral viscous budesonide is to go down to once a day. Food elimination diet can also be considered because, again, with the lifestyle change and doing this long term, it can help prevent frequent relapses. And then for the fibrostenotic type, maintenance topical steroids can be helpful, but you have to really break up that scar tissue and give the patients really a running start so that the medicine actually has some effect in terms of preventing the recurrence. And with that, I thank you for your time.